So interestingly, things often come into your life at the opportune moments, and it's funny what what you're saying. The pathogenic bacteria in the mouth, which clearly causes problems, and is often hidden behind a very nice biofilm of plaque. By the
Agreed.
way, right?
Yeah.
What do you do to address it? And I'll tell you why I asked this. We've been using a hypochlorous solution recently,
Right.
which is a natural antibacterial, antiviral, pretty potent kind of solution. And we've just been using it just by like swirling it around your mouth and then spitting it back out again.
Sure.
But I think from my perspective, I'm doing it more not as focused as you are. I understand it's important that the oral hygiene is good. We can look at people's oral hygiene, give them like a little bit of a questionnaire that asks about their history and have a look in their mouth quickly and whatnot, and we can kind of tell if there's some challenges going on. So as a blanket, which is not good, but a blanket protocol might say, oh yeah, just try this for a little bit. Sure. Let's just clear the area just for now. But yours is much more focused. It's like, right, we can see this is here now. These are the bacteria we can see. So the first question is, how do you then approach that? How do you clear out those pathogens? And then the second one would be, how do you ensure that doesn't come back? So you seal the gums or whatever else it is.
Yeah. So a good question. And I can only answer that based on and we haven't had a huge amount of patients, Paul, that we've been able to put through long-term programs. So I can go off what we've done so far with the patients that we've been able to run long-term programs with. The great thing, it always comes back to the basics. And the reality is that if we're looking at what starts to cause the issue, is that although I have certain arguments on carbohydrates, definitely refined sugars do have an overwhelming influence on the bacterial changes in the mouth. So I think we talked, didn't we, is that the most difficult thing is not actually being able to get the answers for your patients. It's being able for them to make the behavior changes over time. And so what we found is actually really good when you deliver the test results to say, you absolutely need to change your diet here. So that goes with everything, is that there needs to be a behavioral change to the diet. So what we've been basing that on is the more phytochemical dense the diet is, the more likely we're going to get a favorable change to the oral microbiome. So that's one thing that we're going on that, because obviously plant foods per se can deliver a lot of flavonoids and phytochemicals that are going to help that bacterial balance. However, that doesn't mean to say that that's the only way to go, because I think one of the other things, and I think a lot of this, my thoughts on this is that this almost feels, why does this happen? Why does this happen with these subset of individuals? And I think because we have a basis with regards to what would we do on a longevity perspective. So one of the key things on this is that I do believe I'm pulling these patients down to, in many ways, only eating 2 to 3 times a day, because what I want to happen is that there is a reduced exposure time to food and bacteria. So and again, that sort of runs with the longevity process, the intermittent fasting, however you want to look at it. But it makes sense. It makes sense from a point, and particularly with inflammatory genotypes. These inflammatory genotypes, particularly if the ApoE4 risk, are just people who, unfortunately, were designed for a pretty violent and short life.
Yeah, and I'm one of them.
Yeah, and same here.
We're both the same. But it's funny you should say that. I just put a post on this morning on a couple of social media platforms, And then the gist of it was, we forget what it's like to be hungry.
Yes.
You know, we eat because it's breakfast time. Then we look at our clock and go, oh, it's 12 o'clock. I've got to have lunch. And then, mid-afternoon, well, I've got to eat something. And then, well, it's dinner at 7. And then you just do it out of habitual habit, right? Habitual habit doesn't make sense, but out of habit. And we never feel hungry. We don't even get the little bit of growling in our stomach because we're just constantly throwing food in. And it would be really interesting if people just started to just throw the watch away, the clock, when it comes to times that you eat. And just go, look, I feel hungry at the moment. I can hear some growling going on. I'll eat something. And then just wait until the next time.
Yeah.
And I think, like you've just mentioned, that in itself can have some quite far-reaching benefits to people just because they're not constantly bombarding their system with food every few hours.
Yeah. And, you know, the thing to think about is that, again, it's particularly the genetics around this are pro-inflammatory. So in many ways, what you're trying to do is you're trying to give the inflammatory cytokines and the immune system just a bit of a break.
Yeah.
You know, which is, and I suppose it's no one's fault because we were always taught, you know, to stabilize blood sugars. You know, 20 years ago, you had 3 meals a day substituted by 2 small snacks. You know, and I think, unfortunately, that's really for most has been, you know, probably inappropriate advice. But again, if we're talking about nutrition, Lewis Bailey, we had a conversation, didn't we, on a recent post, and you know, I think we both agree that it's very difficult to give advice. For me, it's very difficult to give advice on nutrient advice on anything without understanding the bigger picture of how nutrition fits with everything else they're doing. So if I take you back, so we're working on, again, nothing different, but we're trying to emphasize on why don't we give your mouth and your GI tract a bit of a break? Let's try and elongate that. If we have people who have quite advanced periodontal disease, then it's absolutely crucial for us that we get them to go and discuss it with their dentist, and definitely then try and see if they can see a periodontal specialist. Usually at that stage, Paul, so plaque is a bacterial biofilm. So it is a group of bacteria that have very nicely set up house in a really difficult structure to get rid of. And plaque buildup is exactly that. It's that bacteria building a really solid home, just very difficult to get rid of. So for many individuals, they have to have what we call a deep clean. So they will go to the periodontist, they will be injected all around, so all the gums are numbed, and then the periodontist will go in and really go below the gum line and clean out the bacterial biofilms as much as possible. So this is, again, where having a relationship with a dentist or a periodontist is so important, because I want to say, and this is what I'll say at the conference, I want to be able to have a group of periodontists or dentists I can see, your patient needs to go and get this done because this is what we found and this is what's causing X, Y, and Z. So we definitely recommend that, because unfortunately, you know, there may be some issues with, well, that will cause inflammation and maybe put you at risk of having more bacterial exposure into the body. I appreciate that, but I think at the moment that is the way to go. There is some evidence where some medics, particularly in the US, are using very targeted antibiotic therapies where they can target the individual pockets. I'm not aware of anyone. And what I mean by a pocket is where the gum has receded around the tooth and there's a big sort of hole that the bacteria can sit in. So the gums have come away, and your periodontist or your hygienist will measure those pocket sizes. And so really they need to be deeply cleaned. For us, we're using oral microbiome probiotics, so almost like in a swash solution. So, you know, at the end of the night, you will swill them in. We're using oral probiotic toothpastes, and we're also using a couple of. I think this one is a real breakthrough product for us. We're using some antimicrobial herbs products with regards to both liposomal delivery and toothpaste, which we really having some really good experiences with. And so we're in a situation where we have got individuals who eventually just start to notice that when you get periodontal pockets, you sort of get tiniest bits of food caught, and then it gets all irritated, and then you have an inflammatory response. And we're finding if they're really religious with what we're giving them, like everything, isn't it? It's not a question of this is what you've got to do. It's how well you do it day by day. And we've found that the ones that do are really starting, it takes a while, but they really start to say, you know what, I'm sort of, after 3 months, I just feel a bit less irritated. I'm getting less food caught, which is a sure sign that we're on the right tracks. And we've had a couple back after doing it for a year, where what we found is that the periodontal expert has retaken x-rays, and we're actually finding we're getting bone growth coming back now through the jaw. So, and that is of course because we are dealing with not only the bacteria, we are dealing with the inflammation, and that inflammation, once we've got on top of it, is allowing the bone to start to heal itself and grow back. So we're hugely confident on this. Doesn't work for everyone, and again, it's like everything. These programs can get a little bit complex, and it's a real pain in the butt that you've got to use this sort of stuff, and you've got to clean your teeth well, and you've got to do this dietary approach. But I think we're confident enough with the data that we get at the beginning that this is absolutely necessary. What we're also confident enough is that that oral work has a massive systemic effect. We had a patient recently come to us who has been diagnosed with rheumatoid arthritis. So what the terminology is idiopathic rheumatoid arthritis. No way that they ever suggested why this has happened. But of course, and when you get these sort of definitions and diagnoses, it could be because of a whole host of things. But one of the bacteria that is implicated in rheumatoid arthritis is the one that we found in really quite high levels on her oral microbiome. So there's one mechanism where we can safely say, well, if we start to help you out and get rid of this, then it may have an influence on the diagnosis. It all comes back down to the basics, though. And I'm a firm believer that we've got so far away from. Another example would be, the immunostimulating effects of vitamin D status. But also vitamin D on the mucosal, the mucosal health. And so, if we have a Afro-Caribbean patient with periodontal disease, we know straight away that, God, we need to find out what those vitamin D levels are. So then you start to get that oral and systemic picture and put it all together. So fingers crossed, we are continuing to develop that side, but we're keen that we've seen enough data, enough patients to at least come up with maybe developing a strategy for it or a program for it in the next 12 to 18